everyone just to make sure they're on mute, just to help with the audio feed when we have so many people on the call. We'll just wait about a minute more and then we'll get going. Okay, ladies and gentlemen, we'll get going to this, the November full board meeting. Can I ask everyone to be on mute, please? And we've already had quite a busy day already. Just before we get going on the main body of the board meeting, we tend not to do sort of going the extra mile awards at this meeting, but there are a couple of, there's an individual and a team I really want to have a shout out across the foundation group as having gone and done some exceptional stuff during the last month or so. And the first is an individual shout out to someone who works at Worcestershire Acute, who is Andrew Williams, who is our portering and transport coordinator there. Karen Martin, one of the NEDs at Worcestershire, mentioned to me that on a visit, as a NED visit, she'd met Andrew, who's doing some quite phenomenal work reducing our taxi bills there. So I wrote to Andrew, and what he's doing is a great example of taking leadership and responsibility for something to try and save the taxpayers' money. So on behalf of all of the four boards, Andrew, a massive shout out and thanks for everything you're doing on the saving the taxi bill at Worcestershire, which is a big issue across the NHS. Big shout out to Andrew. Can I also have a big shout out to the UEC team at Warwick Hospital. Warwick Hospital is suffering as a result of its own success at providing outstanding care to the people of Warwickshire. But Monday week ago, they had 393 people attend on one day. And in terms of type 1 attendances, and they're the real emergency attendances that we get into the emergency department, on that day they saw just 5 patients less than the tertiary UHCW ED department, which is well over twice the size of Warwick Hospital's ED department. And they did that and saw that level of demand while still providing enormous civility and kindness to all of the patients. So I just want a big shout out in particular to the UEC team at Warwick for continuing under enormous pressure to provide kind and civil care. Big round of applause. I also want to welcome Hayley, our new CNO at Worcestershire, to her first full board meeting here. Hayley, it's great to have you on board.
Thank you.
You've taken over from Sarah Shingler, and this is Sarah Shingler's first full board meeting in the role of Managing Director at Wye Valley. So congratulations to you both. So without further ado, we have apologies for absence from Chizu. Tom is deputising. Good to see you, Tom Morgan-Jones. Apologies from Paul Capener, Phil Gilbert, Michelle Lynch, Jackie Richards, Nicola Twigg, although I think she might try and join if she's able, and Umar. I think they're all the apologies I've had, Sarah. Are there any other apologies that I should have mentioned?
Not that we've received.
Okay, super. Any declarations of interest? Could you please raise a digital hand for me, please? Barty.
Okay, thank you, Russell. I've got 3 additions that I've put on the declaration of interest form. The first one is that under my consultancy work, I've been asked to join a specialist healthcare, a specialist independent finance firm called Corbett Keeling in London as a healthcare specialist advisor. And the second one is I have been supporting UHB and Swift on a transformation for their aseptic services. Just to declare that I've also been helping other NHS trusts that have approached me where they need help. And the last one is that I'm really pleased to say my daughter has fully qualified now as a GP, and she will be taking up a salaried role within Coventry and has expressed an interest to be involved in research activity to support Warwickshire as well. Thank you.
It sounds as though the whole family's been busy. Barty, many congratulations to your daughter. We've got a few GP colleagues on our boards, and we know just how much value they add to the local community. So fingers crossed for her career. Thank you, Barty. Any other declarations of interest? Okay, so the minutes of the meeting, the last 4 board meeting held on the 6th of August. If there are any points of accuracy on those minutes, could you raise a digital hand for me, please? I can't see any digital hands raised, so I'll take those as accurate, but I will take us to page 17 of our pack, just in terms of some action points arising. And the first was a deep dive into our outpatient work, and to be clinical leadership and engagement for what's called PIFL, or patient-initiated follow-up, to be agreed to help drive delivery. I understand Naj, Jules, Chizzer in absence, and Bhaskar, that was done, and we're going to talk about that a bit later, so we'll come back to that. And then on the UEC and winter plan preparedness and assurance stocktake, the coups were to look into a consistent measure of flow, and we cover that a bit later on the group performance report. We can discuss it at that point. And then in terms of the equality update report, the chief people officers to include the impact, the data in the annual EDI report moving forward, and that will be included on an ongoing basis. So we will ensure that happens. Thank you. Any matters arising that colleagues feel I've missed? Okay, we'll move on to the next point on the agenda. Members of the public will be aware what we do on a board day is we have a board workshop in the morning. We had a series of different presentations and discussions this morning. We had a great presentation on the work we're doing to be at the forefront of working with our veterans and family of our veterans in the 4 geographies that we work on. Some really super work. A particular shout out for Rebecca Farmer, who I think is on the call, for the work she does at Worcestershire Acute. But that work is incredibly important when, particularly in the case of Wye Valley, we're absolutely the heart of a community which is proud to have a military association in the way that it does. We had a discussion on some of our big moves, in particular the fantastic work we're doing on carbon reduction, and some really fascinating things that are great legacy projects, which I think will profoundly shape the efficiency in climate terms of each of the 4 trusts. We talked about our neighbourhood plans, which are part of the 10-year plan to push healthcare to be much closer to home, both in terms of primary and prevention care and social care. Each of the chief strategy officers are pushing ahead with that, and particularly I think in Warwickshire, under the shared leadership work, our desire to become an integrated healthcare organisation will be at the forefront of all of that. And then Glenn kindly presented on some of the work that's going on nationally, which he is intimately involved in. And I did have a shout out for the particular work of Andrew and the UEC team, but members of the public won't be fully aware. But Glenn is working literally 7 days a week to try and help the NHS to achieve what it needs to, given all of the challenges it's got. So Glenn, Thank you on all of our behalves. Glenn, do you think there's anything I've missed out of the discussions from this morning?
No, Chairman, it was a really good workshop. Apart from my bit, it was a really good workshop. I particularly enjoyed looking at how across the group we're tackling that big move of leading the NHS on carbon reduction. As I mentioned during that, I've asked for some national data just to see how we compare with other organisations on that. But it's really good to see the progress on that, but also the way people are working together between the trusts and the group.
No, super. Thank you, Glenn. Okay, well, we'll move on then onto the performance review and update section. Sorry, Simon.
Just very briefly, Russell, I think you might have got your Rebecca's mixed up.
I did.
It's Rebecca Brown.
I did.
For the
I
record.
apologise. Okay. So we'll move on then to the performance review and update section and the Foundation Group performance report. So over to you, Stephen and Adam, to lead.
Thanks. I'll kick off and I'll start with George Eliot. I'll do George Eliot and Swift. So at George Eliot, I think it's really pleasing that we've had some sustained improvement in our cancer targets and our referral to treatment targets. And I particularly wanted to highlight the 52-week performance where we're well ahead of trajectory for the year, with less than 1% of the waiting list over 52 weeks. And that's a really significant improvement on the performance we saw in Q1. It's really reassuring we've been able to pick that up and get back to and beyond where we need to be for those targets. My biggest worry at George Eliot, though, is the indicators related to ED 12-hour standard. We've made good progress with 4-hour waits in ED, and we've seen improvement there. But we have far too many patients waiting over 12 hours in our emergency department for a bed. And this points to the wider issue of flow within the hospital. And really that's driven by the longer than expected length of stay of some patients and the number of patients we have who are medically fit for discharge. These are areas of absolute focus for the teams and for the new joint executive team of Swift and George Eliot over the coming months. And we've identified a number of areas where we believe we can make improvements together with staff across the trust. I think it's also important that the new shared leadership team will be able to help us share best practice from Swift. We know these are areas where Swift does well, but we will need a sustained period of focus on that. It is a real challenge and a worry going into winter. I think it is an area of concern. If I move on to Swift, I wanted to point the positive ED performance, but also set that into context. Russell, you mentioned at the start the UEC demand, and I just want to reiterate that. It has been on a sustained path of increasing over the last 5 years. We've seen something like 35% plus increase in emergency department attendances over the last 5 years. But it has particularly hit us in the last month. We've seen some of our busiest ever days where we very nearly touched 400 attendances, which is phenomenal when you think back a few years, and a 300 attendance day was an incredibly busy day for Swift. I think despite that demand, it's reassuring to see that our same-day emergency care areas are working well and are helping manage those emergency admissions. So we haven't seen the same increases in admissions as we've seen people attending at ED. But if the demand continues at the rate we've been seeing it, we will be really challenged. It's unsustainable. We simply don't have the beds or the capacity to manage that. I also want to note cancer and referral to treatment target. We've been slightly off track for the last few months, notably the cancer faster diagnosis standard. But beyond what's reported here today, it's reassuring that the October numbers are much better. The challenges, particularly in faster diagnosis and referral to treatment, were driven primarily by some issues in the dermatology service, some staffing issues, which we've been able to support with extra capacity. Having said that, we've seen some really significant increases in referrals. I am confident we'll get back to where we need to be, certainly by the end of the year for faster diagnosis, but cancer generally remains challenging, and we know there are pathway challenges across Coventry and Warwickshire that we've talked about here before, and which we are still talking to system partners about addressing. But good news that we've seen improvement there, certainly over the last month. Finally, I wanted to note sickness rates at both trusts remain a challenge. We've approved over the last month at both trusts new sickness policies, because we heard from our managers that the current policies made the process of managing sickness confusing. So those have now been improved. We've also put in some extra support to help managers with the conversations with staff. But I am concerned about the sickness rates, and again, it will be an area of focus at both trusts over the coming months. I think those are the key points for Swift and George Eliot. Russell?
No, very comprehensive. Thank you, Adam. Just before I move on, any questions or perspectives to Adam? Just a couple of things I would like to add, Adam. I think that the point on the UEC demand, which is frustrating, is the level of imbalances in the Coventry and Warwickshire system, where there is such a phenomenal increase in demand into Warwick and to a lesser extent in George Eliot. And we are being overloaded with demand and WUMAS activity, whereas other, in particular UHTW, are seeing declines in their UEC activity. So there is a real need for rebalancing, because, as you say, the current level of activity is unsustainable. The second thing that you mentioned in terms of medically fit for discharge, you're absolutely right. For members of the public, NHSE last month did a piece of work looking at the costs of medically fit for discharge patients being stranded into the acute setting. For Coventry and Warwickshire in total, the number was £48 million a year net cost wasted from patients being in the acute when they should be home. In fact, Warwick Hospital is amongst the very best in terms of medically fit for discharge performance in the whole of the country. We do have some challenges in George Eliot with medically fit for discharge, and I know that's a priority for Harkermel. And thirdly, in terms of sickness, I just want a big shout out for Jeffrey and the team down at Wye Valley, who have done some phenomenal stuff on sickness protocols. It is a real issue across the public sector and within the NHS. Jeffrey and the team down there have done a great job in terms of rolling out a new set of protocols which are having a real impact. And I know that is a across the board level of management that's going on, but Jeffrey, you can be the hero on it at the moment. Any other questions or perspectives to Adam before we move on, Glenn?
Yeah, I was just going to pick up on the UEC demand issue. As you quite rightly say, part of this is about patient choice, but I think just to reassure the public, and I know the board met earlier today to look at how we can expand the capacity on the Warwick site. We've recently expanded capacity at the George Eliot site. I mean, ideally, this isn't about creating bigger A&Es. The right solution is to have better flow and to treat more patients closer to home, but we're trying to balance all of those things, but we are taking some action.
Absolutely. And, you know, Fiona popped it into the chat box. We did have a visit by CQC actually on that Monday when we were unbelievably busy. I think they arrived at about 8 o'clock at night and saw the challenges we were facing. And the early feedback is, I think, that they were very impressed with the care and consideration and kindness of all of the team, despite that level of activity. So well done, Rachel, Harkermel and everyone involved in that with Fiona's team. Okay, we'll move on then. Not sure whether I'm going to Sarah or to Stephen. Ladies first. Sarah.
Thank you, Chairman. So I'm going to follow in Jane's footsteps and give a positive first, and that is around our financial performance. Over the first half of the year has been strong. We're 1 million better than planned year to date and have delivered 10 million of our 25 million efficiency savings. I am blown away, I have to say, by the really good engagement from the clinical and the operational teams in relation to cost improvement over at Wye Valley. But we're not being complacent. We absolutely recognise the challenge in the second half of the year is greater than the first, and we're working hard as a team to support the divisions to deliver those targets. More of a challenging position is around our UEC. Our type 1 attendances have been we've had the second busiest month of the year in September. However, what we have seen in the first 2 weeks in October is a reduction in our attendances, and we remain below average at the moment. So we are doing a piece of work just to understand whether this is true and that this will continue, around the causes around that reduction in attendances, given that we've primary care have put some new initiatives in the last 4 weeks. Our EAS remains challenged, so all type EAS performance is at 66.7%. And we're off our trajectory by 0.7%. So we are closing that gap and improving. Our non-admitted performance is at 78%, but our challenge is very much around our admitted, which is at 38%. And that is where the area of focus is with Andy and others working with the teams. 12-hour performance in the department, again, is not where we want to be. We're currently at 11.8% and we're off trajectory by 1.4%. And ambulance handover delays, we are at 68%. What we have seen in October is an increase in pathway delays. And this is partly been due to a loss of a care provider in Herefordshire, which has meant that a number of emergency packages needed to be sought over a week period. The other issue for us is Powys, and the number of delays in the hospital continues. So Powys patients take up 30% of our bed days lost. And this has been the highest in September since May, and our Powys patients stay in our beds 1.8 days longer than our English patients. There is work ongoing, and Glenn is supporting us with the national team around conversations to move forward on that position. And lastly, around our RTT position, our validated position for September was 62.2%, and we had 42 patients over 65 weeks at the end of September. We are improving and we are delivering our plan. 52 weeks, we had 698 cases at the end of September, which was an improvement of 80 from the end of August, and that unvalidated position is at 62.8. So we are making progress across all those areas. Thank you.
Thank you, Sarah. Any questions or perspectives to Sarah? Glenn?
Yeah, I think flagging the delivery of some of the financial improvement targets is a good one, because I think when you look beneath the surface of that, I think there's two things going on. One is doing more elective work, reducing waiting times for patients. The other one is innovation and improvement work. This isn't about cutting the cost of services in a bad way. This is making them more efficient. So well done to the team for that.
And particular shout out to Lucy, the CNO down at Wye Valley, for her management of the nurse agency costs, where the performance there is quite extraordinary. Any other questions or perspectives? Okay, I can't see any hands raised, so I'll go to Stephen. Stephen, how are things at Worcestershire?
Thanks. And again, I'll probably pick up some similar themes, but I just will take a slightly different tack with maybe some of the messaging that we're given and some of the priority and work that we're doing. So in terms, I wanted to draw out in terms of where we're at with finance. So we've done well in the first half of the year. We've got a massive challenge that steps up to deliver the biggest efficiency challenge the trust has probably ever delivered. We're not shy about that. We know we need to do it. But there's one area in particular, or two areas, that I want to pull out as starting to show some real progress. So one is around our job planning, which has traditionally been quite a difficult area for the trust to achieve, and we're benchmarking. We were one of the lowest. We're benchmarking up at the 70%, which it puts us right up back in the pack. And there's a really clear plan there from Jules and the team around how we're moving. And actually, despite what people may think, with the trust history and looking inside, there's actually some really positive engagement from the divisional leadership in that space. So that's definitely encouraging through the year and into next year. And the other thing that's following on from that is our reduction in temporary staffing. So we were one of the highest users in previous years. 8% we were using. Our target was to get to around 2%. We're currently running at 4 to 3, and that's on a 6-month downward trajectory of that. So that's good. We balance that with some of the bank work, but again, that just buys us the headroom to do the structural things that we need to do. My other theme through all of this, and we'll do it in the cancer deep dive and we'll do it through the performance review, is we really are in a cultural shift of trying to simplify. The trust, I think, in the past has layered on and layered on and layered on, and then we're actually not so much stripping back, but trying to keep it really simple. And my link to that is around the second F that I was going to talk about, which is flow. So we are making some real progress around the absolute number of discharges that we get during the day and the length of stay that we see. But a big focus for us in our kind of UEC work as we go through the next month, again, stripping back. And it's really pleasing to see some of the plans that the divisions have got in place around our acute medical model, our frailty model, and our surgical assessment model, where probably for the first time it will be quite standardized. They'll all be working to the same timeframes. We've had a focused piece of work around bed moves, so not just length of stay, but how many times we move a patient round, which is a real indicator that the hospitals are under pressure. And there's some real work coming through there, which is encouraging. We have seen an increase in demand, but I think I would slightly take a different view to. I think we might be in a slightly different place to some of the other trusts, which is particularly conveyances by ambulance have gone up by 11%. That is likely to be a repatriation of Worcestershire work that was going outside of the county is now in the county. So it's a really difficult balance. It's really difficult for colleagues that are working in those areas that just see this demand going up. But I think it's really important for us as the senior leadership to take that responsibility on and to work through those solutions that we're dealing with it, and not to get into with other colleagues around they need to be doing something radically different. We all need to work at this together to come up with the best solutions for our urgent and emergency care pathways in Worcestershire. So that they really were the main things that I would draw from a performance point of view. But the last thing I would say, we are absolutely cognizant, and we've had some difficult conversations, I would say, at board around the numbers are in there, but this is people at the end of it. And I think we never forget that. And Hayley and I have met with a number of people over the last couple of months that have had not the best experience from moving through our UEC pathway, and we're really cognizant of that. And finding ways that we don't overload our clinical teams with that, but we use that as a springboard to make this better, and we keep going on that journey of making this better. So they're the bits that I wanted to draw out, Chair.
No, very helpful. Thank you, Stephen, and thank you for your openness. Questions and perspectives. Glenn?
Yeah, I think one of the things you just touched on there, Stephen, about the UEC demand profile issue and the increasing ambulance attendances, but I think it's true of all of the A&E departments in the group that there's a correlation between the patient's home address and proximity to the A&E department in terms of the number of attendances we get. So I still think, and I know you've done some recent analysis of that, I still think there's still a question about whether alternative primary care pathways could still be encouraged in those areas.
Absolutely. And when I say that, it's not that we're saying we don't want to do that. I think we have done the analysis and it clearly comes through. The proximity to the hospital is a real driver. You can see that. So I think we're working closely with primary care colleagues, ICS colleagues in the community around what points can we step in to intervene in that journey that they don't end up in our emergency department.
And any other questions or perspectives to Stephen? Okay, Hayley, I know you've only been with us now a couple of months, but I think you're having a sort of a great impact. So it's great to have you on board. But I think just going back to some of the difficult discussions that Stephen referred to there with patients having had a bad experience. No A&E department in the foundation group is as busy as Warwick. Fact. And at Warwick, we do not have unkindness or impoliteness or rudeness towards patients or other members of staff. And so as a team, we need to always hold ourselves to the highest standards. And we need to move from a situation of finding excuses and reasons for why things aren't the way we would like them to be, to finding solutions within our power where things can be better. And I think your comments about medically fit for discharge in that regard, Stephen, are absolutely essential, so we can minimise the dwell time of people in A&E, because we've got availability within the wards, but we can only have availability in the wards if we've allowed the medically fit for discharge to go home. It's not rocket science, it's just about flow management. So I know the work you're doing will bear fruit, but in the meantime, let's all hold ourselves to the highest standards in terms of behaviour and kindness. Any other questions in general to the chief executives or MDs? Okay, team, we'll move on then to the deep dive in terms of cancer performance. We are very cognizant across the foundation group and each of the boards how worrisome a cancer diagnosis or a cancer test can be, and how important it is for things to happen quickly. We know that as a country, our cancer outcomes aren't where we want them to be. And as a foundation group, we are very reliant on tertiary partners to drive the cancer performance that we're able to achieve to the levels that we want. But over to my coups to give us that deep dive. Harkema, are you going to lead us?
I'm going to finish up, but Chris is going to start us off.
Okay,
I'm
so
start.
Chris.
And I will share slides if that's useful for everybody, so that everybody can see them. Hopefully you can see those on the screen.
Yes, we can, Chris. Thank you.
Thank you. So Russell, like you said, clearly earlier diagnosis and quicker treatment for patients with cancer remains a key priority for the NHS and for us within the foundation group. Harkema and I are going to take us through the deep dive today. And I think it's fair to say, for those colleagues on the line and anybody in the public who's looked at the papers, there is certainly more we need to do in terms of improving our performance in this regard and getting it right for our patients. So the focus of today very much about the standards by which we are monitored for the first half, and then Harkema will go into a bit more detail about some specifics and some areas that we're doing well and some areas of challenge across the group in the second half. So the standards are around 28 days faster diagnosis standard, so how long between being referred with suspected cancer to getting a diagnosis of cancer or not. And for the vast majority of people, it is a or not. How quickly we treat people after we've agreed that they need treatment, around 31 days, and how long that whole pathway should take within 62 or no longer than 62 days from referral to treatment. The data in here looks at the combined period for April to August combined and overall trend over a slightly longer period. So I just talk through each of the main headlines for each of the slides. So for 28 days, there is a variation across the group in terms of our performance in this regard over that period. And we're still doing particularly well compared to other members of the group. But that said, still quite a long way, and Wye Valley doing even better. Numbers of referrals, though, Worcester has the highest number of referrals across the group, but we're not meeting the faster diagnosis standard that's been set for this year, around 80%. There are variation again in the group around places that individual organisations are doing well, so more areas we can learn on across the group, and that's set out on the left hand of the slide. So for George Eliot, lower GI and lung pathways, South Warwick doing opportunities to improve in head and neck and skin, and opportunities to improve in Worcester around urology, in particular around faster diagnosis standard. And Wye Valley, more work to do around breast, and there's some work we're doing with Wye Valley from a Worcestershire point of view in terms of supporting elements of that pathway. As you can see on the bottom right, though, there is, variation within over that October 23 to August 25 period in terms of our in-month performance in each organisation and in terms of the group position. So there is certainly more we need to do. And we know that getting 28 days right for those patients that have cancer absolutely drives forward in terms of us being able to deliver quicker access to treatments around 62 days. This one I wasn't going to go into in terms of much detail because I'm very cognizant of time. There is lots of detail on here, but this just shows for each of the organisations a collective position, both in terms of a number and in terms of a bar chart around specialty specific or tumour site specific performance. And those in green are where we achieved the faster diagnosis standard for last year of 77%. So there is some areas we've done well in as at the end of last year and continue to do well in, but some areas we still absolutely need to do better in, and those are the ones that I've set out in the summary before. If I then move us on to 31-day standard, so the standard for 31 days is 96% of people should receive their treatment once a decision to treat has been made. Again, there are some good performance around 96%, particularly at George Eliot and Worcester. We are, challenged around that at 83.7%, and that particularly is linked to skin, urology, and head and neck at Worcester. But some really good performance at a tumour level site at George Eliot and most places in South Warwickshire, the opportunities around gynecology, and again opportunities for Wye Valley around improving the best performance, but some really good performance in other tumour sites where Wye Valley are achieving 100%, which is really good to see for our patients. The other challenge we do have is about, as a group, is about access to tertiary providers, and in terms of where patients are receiving their care on a tertiary basis, that does impact on some of the numbers that are reported compared to the number of diagnoses. But I won't go into too much detail because I'm conscious I can get quite technical in that regard. And again, similar to the 28-day chart here, again, lots of areas as I've talked through in terms of doing some really good performance. But as you can see, I think it sticks out like a sore thumb, but partly because it belongs to Worcester, is that skin's performance around 31 days at 60% absolutely isn't getting it right for our patients. And we have got a plan in place that will see that, because I'm conscious that members of the public will be aware we've had some challenges in that service for a number of months now. And then a little bit on 62 days. So this is an area we've all got to make improvements. The standard is about getting to 85% overall, and we're all got lots more work to do in this regard. So opportunities to improve in George Eliot in lower GI, skin and upper GI. For South Warwick, it's about lung, urology, head and neck. Worcester, it's about breast and urology, and Wye Valley is doing really well in some of those areas around lower GI, lung, skin and urology, and we are doing some work, particularly Wye Valley and Worcester, around how we're using that to help Worcester's urology service. So we are doing some work across the group in terms of how we can share some of this capacity to help get it right for patients. But as you can see, big variations in terms of in-month performance and some variations between where overall each of our trusts is delivering. A similar chart to the one before, right, 62 days in terms of where we've done well around those in green, but again, there's a lot less green on this chart compared to some of the others, and this really is where we've got some work we need to do. But this one is the one that is most impacted by that tertiary work. So if patients are referred to one of our organisations and go on to receive their treatment in a tertiary centre because it's a specialist service that we don't provide within the organisation, we need to have that whole pathway completed within 62 days, and where that's not possible for one reason or another, that does impact on our reported performance as well, but ultimately is impacting on how quickly patients are receiving their care. Kamal, over to you.
Thank you. So for transparency, we thought it was really important to highlight where members of the foundation group are really struggling, and George Eliot and Swift are two of those. So George Eliot is in tier 1 on cancer performance. So currently the performance regime as prescribed by NHS England says that you're in a tier 2, which means additional regional oversight if your performance is off track. And for areas of significant concern, you have national oversight, and that places you in a tier 1. So George Eliot is in a tier 1 based on their cancer performance. As they are currently under trajectory for both the 28-day and the 62-day standards that Chris has just talked about. But there is an improving picture for these backlogs, and we've seen a lot of that since June 2025. And I think it feels quite disappointing that we remained in this tiering, not being de-escalated to tier 2, because we have met all the trajectories that we said that we would meet for both George Eliot and for Swift. For George Eliot, the aim to get to the 28-day faster diagnosis standard, it says the end of, our trajectory says the end of November, and 62 days then will follow in December. We have a number of reasons for delay. So the diagnostic pathway is really, really challenging. And certainly if you have delay diagnostics, that then obviously feeds into the rest of the pathway. And the actions around escalation plans and waiting list initiatives, as well as some process improvements, have been detailed in the slide. And then if you move on to Swift, Swift is currently in tier 2, which is obviously very disappointing. We are expecting to be upgraded to a tier 1 because of our continued challenge around cancer performance. This for Swift is driven by our skin cancer demand predominantly, although there are challenges within some of our other big tumour sites. We knew that this was going to happen. This was quite predictable when we saw the record levels of demand that we were seeing on our suspected cancer referrals, and then with consultant sickness that we've seen in dermatology with one of our full-time consultants being quite poorly. So we actually escalated ourselves that we recognised that this was going to be a challenge. We've also seen a little bit of creep from out of area demand, and it as part of the performance management framework that I've sort of just alluded to, it's the bi-weekly meetings, and both Swift and George Eliot are part of those. The trajectory for Swift to get back on track was always November, and we are on track to hit that. So in terms of some of those more detailed recovery plans, everything that we said that we would do, we are there or thereabouts, which I feel is really important, both George Eliot and for Swift. We submitted our trajectories, and broadly we've managed to stay in line with those, despite the fact that the referrals didn't ease off, and it has been a really, really challenging picture for Swift, certainly. In terms of going back up to the foundation group, so the key challenges across all of the trusts on the next slide will talk about some of our challenges around our workforce. The reliance on the bank and locum staff is really, really difficult. The recruitment challenges, I think, can't be understated, because as soon as you lose one part of that puzzle, it's really, really challenging then to kind of pick up the slack elsewhere. We've talked a little bit about diagnostics, but that shortage of pathology space, pathology workforce, some of the interdependencies there are really, really challenging. And then that struggle to meet the faster diagnosis standard really then does impact on the rest of the pathway. That first 28 days of the pathway does make up the overall 62-day as well. So if you're not, it's mathematical. If you're not meeting one bit, it's really, really challenging then to kind of meet the rest of it. And then there's variation in how we are recording our patients on EPR, what our cancer databases look like. Dashboards aren't necessarily standardised. Worcester has a brilliant dashboard, which I think all the rest of us are desperately trying to copy. But some of this makes just the infrastructure around it really quite challenging. And then finally, just the challenge around how our partners are using that urgent suspected cancer referral pathway has different impacts across different pathways at each trust. From a good practice and shared learning perspective, we have all struggled with cancer for a really long time. So this is a kind of bread and butter to us in terms of asking for help and working together to try and see what we can do to kind of share the knowledge. And it's really helped in areas such as improving CT waiting times, the one-stop gynae clinics, and as I've just alluded to, understanding the opportunity with the shared dashboards. There's also lots of collaborative learning around escalation policies and observing each other's cancer meetings, and really taking some of that into empowering some of our nurse specialists. And we're looking at what those new pathways and joint posts can offer us, and going down that route with performance data and training modules, which I think is really brilliant. And then the next slide just talks about some of our successes and ongoing challenges, and specifically drawing out the living with and beyond cancer. So this work is a programme of care designed for individuals to support them from the point that they're diagnosed through their treatment and then beyond. And it feels really important that we don't just, often with cancer, you get so bogged down in the metrics of 28 days and 62 days, but the very real impact on these patients who are living with, through some of the worst times of their life and then beyond that, is a real key area for all four trusts. And we've detailed some of the successes that we've all sort of had, and we are indeed learning from each other. But there are some challenges in terms of just like really practically, are we good enough at doing the treatment summaries? Do patients know about how we can stratify them on follow up? And some of those funding constraints definitely feed into some of the challenges. But it is a really key priority area for all four trusts, and a number of actions that have been detailed on the slide. And then if you move on to the next one, we've detailed just some of our cancer patient surveys there, just to kind of build onto the point around where it's really important that we hear back from our patients to understand if we're doing the right thing or if there's another area that we need to be focusing on. And there are a number of action plans that sit behind the results of the cancer patient survey, which we have detailed on this slide as well. And then finally, in terms of the actions that we're going to take forward, the workforce feels like a really key part for us. That reliance on such a strained workforce is a real challenge. And so sustainability for our staffing is vital. There's lots of other areas around our performance and our processes, like all four trusts have different areas of excellence and different areas where we can learn from. And so that work has been just invaluable to have a friendly ear to just go and ask for help, and a friendly set of eyes to come and observe your work, especially on cancer, because it's so challenging from a national perspective. And with that oversight, just having kind of a friend to call in and just double check your homework is really, really helpful. And then, as I think we sort of both alluded to throughout the presentation, that maintaining shared best practice, it feels really, really important. And so to continue to strengthen that, and especially along the data line, will continue to be a focus for us. Is there one more question?
Thank you, Harkamel. Questions and perspectives on this incredibly important issue and one of our biggest areas of challenge. Glenn.
Yeah, thank you both for going through that. It's really good to see the level of sharing that's going on across the group and the cancer managers getting together. One of the areas where I thought we might see an opportunity to implement wider best practices around the teledermatology pathway, particularly the one that we've developed at Wye Valley. Is there an opportunity for improvement there? Have we done the maths on how that changes the amount of activity that's coming into the acute setting?
If I'm honest, Glenn, the only reason we got as far as we have got with Telederm at Warwick is because of Andy's support from Wye Valley. We really challenged with that implementation at Swift, and having the consultant support and those pathways that we could just lift and shift is how we got to where we've got to. The maths for us isn't it's not looking the same in terms of that avoidance of referral. And so I think the opportunity is demonstrably greater at Wye Valley. We just haven't seen that yet, but it's probably because Swift are just a bit too late to the party and we haven't got enough data yet. But we have absolutely got that the baseline from Wye Valley and the work that they've done, and very grateful to them for sort of giving us the nudge to get it established at Warwick.
Well done, Andy and team. David?
Yeah, Harkamel, you did have it on your last slide, and as everybody who knows who works in the area, some of these pathways are extraordinarily complex, and it's all pretty manual, sort of coordinating MDT, MRIs, patient holidays of consultants. You mentioned AI. Is there any software support that we're looking at in detail because I know from my old experience that we've wasted capacity at times simply because we didn't know someone was on holiday or an MRI machine was down or something. I just wondered if there is any more detail around sort of software support for these highly complex pathways.
Great point, David. Harkamel, your view on that?
Yeah, we've got it in pockets, I would say. I think you're entirely right. It's really challenging, and I've never known the level of patient choice. I've been, 20 years ago as a booker, so I understand it from like all parts of the pathway. But the volume of patient choice that we've got, as an example, is just phenomenal. So adding that complexity in, overlaid by all the complex diagnostics that we need, is really, really challenging. So we are using things like Beetroot for patients on follow-up, so we can stratify that and risk assess whether the patients need to be coming back in or not. And there are examples, you know, of like of different variations. But there isn't anything that looks at the pathway end to end. NHS England are looking at or have developed or developing a tool to try and manage the cancer pathway in a lot more in a way that's perhaps more streamlined. So we have put our hands up at George Eliot and at Swift to try and say that we will be happy to be part of a pilot for that. It's a bit constrained by the EPR journey that George Eliot and Swift are on, but you're right, I think it's definitely an area that fills a bit of a gap for the NHS, probably not least because of all the complex bits of the pathway. But very open to ideas.
No. Robert, thank you, Harker.
I was just going to ask about the national and regional tiering support, and to what extent are those interventions tied into any kind of medical workforce planning, either with the kind of postgraduate deaneries or, I mean, can those interventions lead to any kind of coordination around the people coming through the pipeline? And I appreciate cancer care goes far beyond just medical posts.
Chris, do you want to come in on that?
So, Robert, I guess Worcester was in tiering for quite a long time around cancer before, and is still in, well, is again in tiering for cancer in tier 2. I think it's fair to say that it's very much focused on the here and now, and recovering back to your plan on the whole. That said, there's definitely conversations as part of our tiering experience about what else we need to do. But my sense is it's not feeding into a longer term plan for increasing the workforce in the way that you described.
Okay, thanks.
Glenn, did you want to come in on that?
Yeah, feeling like I'm an NHS England apologist now. One of the things that I know we are about to do is to review the way that tiering works in 2 ways. One to pick up the point that Harkamel said, that if you've agreed a trajectory, then if you're delivering that trajectory, why are you remaining in tiering, or even in some cases escalating in tiering? So I think we need to sort that out. But I think we also need to make sure that the interventions that are offered are adding value. So I think, you know, Harkamel talking about how there's potentially an IT solution to this and NHS England can connect us to that is great to hear. But otherwise, I hear a lot about these tiering meetings just being meetings to discuss numbers that we're already aware of. So it needs to be an added value. So it's under review, Robert.
Yeah. Can I ask a simple question to my co-hosts? Which is, we know from study that early diagnosis of cancer leads to better outcomes. It's all about getting that early diagnosis and early treatment. What are the 3 key things that are delaying us getting an early diagnosis? Harkamel.
Wow, that's a question. I would say capacity from our diagnostic end. We have seen, if you take our imaging diagnostics, for example, a significant increase in the volume of tests that we're doing from a UEC perspective, and then from an urgent suspected cancer referral perspective. So actually, even though we are working incredibly hard to try and implement more straight to test pathways, especially down all those routes, the capacity is constrained. So we will talk about wanting to increase our scan capacity, for example. The workforce is a challenge. The capital to buy the additional scanners is a real challenge. And I would suggest that that would be definitely an area of focus, just like a very basic. And we've seen where this really works. So FIT testing for colorectal suspected colorectal cancers, once we had done that piece of work with our GP partners, has really demonstrated that early diagnosis really does make a difference and improves the pathway for patients. But it only works if you've got that capacity to go into. So I would say that. I would say the second thing for George Eliot and for Swift is the understanding around going to the GP. So we have seen in Swift, for example, an increase in patients being upgraded to suspected urology cancer for patients who've come in through ED. And when we've looked into some of those patients more closely, what it looks like is that they had a number of those symptoms, but didn't present to their GP, got quite poorly, came to A&E with something else, and then all with a related finding, we found that. So that early engagement in primary care, I would say, is really vital. And then the third thing is adequate pathology. If we are seeing delays around the pathology, down pathology pathway, that diagnostic then is really challenged. And when we talk about that 28-day faster diagnosis standard, that standard means, do you know within 28 days if you've got cancer or not? The only way you're going to know if you've got cancer is if the pathology bit of that has been done. So I would say to me that they're the three areas.
Okay, thank you. Chris, Andy, do you agree with that? Don't sort of, I want to sort of move on, but do you vehemently disagree, Andy?
Yeah, I think we've all got our various challenges of diagnostics and pathways. I mean, Wye Valley, I think it's endoscopy is a challenge. I think that's, potentially, well, it is one of the areas where that 28 days is a real challenge. I mean, with our CDC coming along, some of the sort of CTC and MRI prostate should improve, but then the reporting and the pathology is probably the area of most constraint, along with, I would say, endoscopy capacity.
I don't want to run down rabbit holes on this, but what I want us to do is, because this is so important to our patients and our citizens, I do want to keep this dialogue on cancer performance going forward at the full board meeting. So thinking about what our three key things that are stopping us and being clear about the actions that we're undertaking to address those three key things can give us assurance that the situation is going to improve. So I do want to come back to this. I do want to get to Glenn, but Chris, is there anything you want to add? Don't speak for the sake of speaking.
I'm not going to speak. I guess the one I want to add, Russell, there is lots of screening programs either out there or being launched. So there's lung cancer screening. We've talked about FIT. It's about making sure that one, as a system, we've got the right, as providers and as systems, we've got the right resources in place to deliver those effectively. And dare I say it, it's also making sure that members of the public who are listening, who have got concerns, are accessing the screening when they absolutely can and are eligible, because those are the times we will find patients' cancer at an earlier stage, and it will be quicker and easier for us to treat it. And it will also, from a financial lens, is more likely to be cheaper for us to fix it as well and give them better outcomes in the long term. So there are loads of benefits to accessing the screening programs where they're available and where you're eligible.
Okay, very good point, Chris. And David makes a point in the chat box about the enormous increases in demand, which I recognise. Glenn, I'll give you the final word, then we'll move on. A very important discussion there.
Yeah, I was going to add the public health message, as Chris did, about screening, which I think is a really important part of it. I think the other one for us, and I think it's a challenge back to all of the trusts in the group. Now we've got more diagnostic capacity, including community diagnostic centres, and we've officially opened the Wye Valley one in the next couple of weeks. Just making sure that we've got the ability to give direct to test access for primary care, so they're not having to come through consultant referral. So I think just sense checking whether we're actually delivering best practice on straight to test.
I would like this to be on our next full board agenda again, if that's okay. But in particular, what I want to pull out a little bit more than I've heard today is where the capacity constraints are. Are they within our control? Or are they, for example, in pathology services, where we're part of a system? Or are they in tertiary partners? I'd like a little bit more granularity on that, but just focusing on those sort of three areas that you highlighted, Harkamel, on the three big things to get that early diagnosis. If we can come back to that when we're thinking about the agenda for next time, that would be super. But really informative session, and I'm very conscious of the enormous amount of hard work that goes on across the whole of the foundation group to try and improve this, and losing people like Alison Bedlow to sickness, I know has been a particular challenge for the team over at Swift. We'll move on then to the gender pay gap annual update. My chief people officers, over to you.
Thanks, Russell. I'm going to start us off. So I'll take the report as being read. So just to remind everyone in terms of the gender pay gap, this is a national requirement for certainly under our obligations of being a public sector organisation to report annually on the gender pay gap. So we've obviously worked as a group in terms of showing the comparisons, and Ali and Jeff will take us through a bit more detail around that. In terms of the NHS generally, and I guess I know you'll all be aware, we do employ the majority of women, so around 70 to 80% of the workforce nationally is women, and that's no different for the group also, so we're certainly in line with the national picture there. We tend to see also from a national perspective that women tend to be concentrated in the lower paid roles, whereas we have more men in managerial roles as well as higher paid clinical roles. And again, from a group perspective, that also is reflective. And again, some more work and actions that we are undertaking to try and redress some of that. So in terms of reporting the gender pay gap, as I said, this is 2025's data. And also in line with some of the other equality and inclusion compliance reporting that we need to do nationally, so the workforce race equality standard and also the workforce disability equality standard, which again, I'm sure at some point we will also report through to the board. Just to let colleagues know also, so we are expecting a new mandatory update in terms of the gender pay gap to reflect the nuances that we see around intersectionality. So we're expecting that to come out in 26-27 financial year. So we will be able to report then on gender pay gap by disability and also ethnicity. But I'm just going to hand over to Ali just to take us through the report.
Thank you, Matthew. And I think some really important points that Ashley's just made there is really, despite that prevalent representation of women in our workforce, we know that they're concentrated towards lower banded roles predominantly. So the gender pay gap exists not because of unequal pay for the same work, which would be illegal. It's around that representation in job bands that really makes a difference when we're looking at gender pay gap. And I just think that's an important distinguishing factor in the gender pay gap that people can often get a bit mixed up on, that it's not about an equal pay issue, it's around that representation that will often drive this as well. And our terms and conditions are set nationally, and people are predominantly paid more the longer they serve within a band as well. So there are some structural aspects there that we're working within as well, which can influence this. In terms of what we can do about it, so we've made some progress, but it's really not quick enough in terms of where we need to go. So whilst that gap is closing, it's closing too slow. And you could argue that is across the whole of the NHS as well. But obviously from a group perspective, that's something that we as Chief People Officers are really focused on in terms of what are all the other factors that are within our gift to control. So they're things like ensuring that we are a flexible employer, and we know as one of our big moves that is a priority for us, but it's about recognising that predominantly women will also tend to traditionally take on those carer roles and may therefore gravitate towards lower paid part-time roles to be able to support those caring responsibilities. So it's about making sure that we've got the right policies and processes in place to be able to support that flexible leave. Similarly, also supporting things like flexible paternity leave as well, to make sure that we're supporting the whole family in that situation to enable that flexible working and career progression, and really look to remove as many barriers as we can. Some of the great work as well that the individual trusts are working on, which really operate as a theme across the group, are showcasing individual stories, looking at things like our women's networks and other forums where we can really celebrate and promote that positive progression as well, which are all aspects that help us to close the gap. So as alongside that continuous review, if you like, of our policies, there's also the bit about staying ahead of some of the legislative changes as well, and making sure that we're really on the forefront of any of those changes as they come through. And I think we benefit from that wider NHS position there, in that many of our policies are family friendly, but there certainly still is work to do to support women as they progress their careers and really help to try and close that gap whilst we work within those structural constraints that we've both mentioned there. I think they were the key points I really wanted to highlight. I'll take the report in detail as read, but I'll just pass over to Jeffrey, who'll run through the final themes.
Oh, thanks, Ali and Ashley. Well, as you've both covered already, there's still some work to be done in closing the gender pay gap across the health and social care sectors. Well, closing the gender pay gap is not just about the numbers, it's also about increasing the support that we have for female employees. I mean, Ali has mentioned things to do with career development and progression, mentoring, coaching, and leadership development programs. So all those are things that we are determined to extend throughout the foundation group and offer more opportunities for flexible working across all the different pay job roles that we employ within the foundation group. So our HR and OD actions on closing the gender pay gap centers around making the foundation group a more attractive, a more compassionate, a more model employer of choice. So if you enhance your reputation along those lines, that then gives you some added advantage in terms of trying to support and develop your female employees into all the different positions. We've now set up female-led networks across the foundation group, and those networks will be working actively with our HR and OD teams in terms of addressing some of the actions that we've captured in our slides on the gender pay gap areas. We are confident that working with the networks over the coming year, we'll be able to address certainly the red areas highlighted in our slides, and we will continue to review and ensure that best practice is being shared across the foundation group. So more work to be done, but we're confident that working with our networks, we should be able to start putting some more actions in place to address some of those concerns. Those are the points I wanted to cover, Russell. Happy to take any questions.
No, thank you, team. Any questions or perspectives from colleagues? Glenn?
Yeah, that was really interesting. Thank you. I'm thinking out loud, which I probably shouldn't do in a public board meeting here, but just I do wonder where we've pushed for being a very flexible employer as a big move, whether that could create a situation, as you imply, where more part-time workers have career progression affected by doing fewer hours and maybe changing their roles a little bit. Is there a way of looking into that, Jeffrey, or is that one of the things that the working groups are particularly looking at? Because that would be a bad outcome of being a very flexible employer.
Yeah, now that's a good point, Glenn, and that's certainly an area that the working groups will be taking on. So I want to explore those as well. So you see on our slides, there's a lot of things we've got to do with data analysis, and that's one area that we will pick up as well.
And any other questions or perspectives? So can I just make sure I understand on page 69, the employees by pay quartile? Okay, always worth asking the stupid question in my life experience. So if I understand that chart correctly, in George Eliot, of the upper quartile of pay, 83% are female and 17% are male. Am I reading that correctly? Whereas at Worcestershire, the upper quartile, only 67% are female. Am I reading that correctly?
Yes.
Yes, Russell.
Okay, super. Because I think sometimes when you look at big trends, particularly on issues of historic inequalities and unfairness, it's sometimes worthwhile just taking a step back on areas of progress. And I think in terms of gender equality, and I speak as a male, so I apologise for my male outlook, but it's something I can't biologically do anything about. But I think enormous progress has been made in terms of gender balance and from over the last 20 or 30 years. And when I look at those numbers, I think it's wonderful that in the upper quartile of pay, 83% of those in the upper quartile of pay are George Eliot, using that as an example, are female. Wonderful. I do think Grace makes an important point on the intersectionality of pay gaps, which would be interesting to come back to at a different point. Because whilst I hear the issue that Ali made, which is clearly it would be illegal to pay someone for the same role in a differential way based on sex or based on race or any other characteristic. It would be good to understand that. But I think that the NHS has been a pathfinding organisation in terms of a series of issues on closing inequalities and removing them. And we need to just continue that journey. I think enormous progress has been made on gender. We need to make sure the same progress is made on race, disabilities, and all the other characteristics which are important. As a foundation group, we are interested in your talent. Everything else is irrelevant. Talent, competence, hard work, and values. That's what we're interested in, and that's what we celebrate. Thank you very much for that update. Look forward to seeing it again in due course. We'll move on then, I think, to the PIFU, Patient-Initiated Follow-up and Clinical Engagement update. Over to my Chief Medical Officers.
Thank you, Russell. So in Chizo's absence, I said I would take the lead on this one and just step you through the information we've provided. So just as a reminder to board and to any members of the public who might be watching, patient-initiated follow-up is a process by which we can give patients and their carers flexibility to arrange follow-up appointments as and when they need them. The patient essentially initiates an appointment when they need one based on their symptoms and individual circumstances. It can be used for patients with both long and short-term conditions and across a range of specialties, and it helps empower patients to manage their own conditions, facilitate shared decision-making, and is very much leaning towards that patient-centred approach that we're trying to get to with all of our kind of clinical interactions. From an organisational perspective, the benefits are the support towards the elective reform plans and management of waiting lists, which clearly is beneficial then to the wider kind of population and public if we can treat people more efficiently and in a more timely manner. As to our previous discussions regarding kind of cancer weights and things like that, it's very important. So it all links together. So in terms of PIFU, you'll see from the data we've provided that actually as a foundation group, we perform quite well in this space. The national target currently is 5% of follow-ups should be PIFU or 5% or greater, and we do achieve that in the majority of, or the majority of the group. Sorry to George Eliot, they're just shy of that currently, but have made some really good progress in that space. So I'm sure we'll be very shortly up to that point. And all of the group members do perform in the upper quartile for some specialties in some areas. So there's some really strong performance across the foundation group in the PIFU space. In terms of the clinical engagement piece, we've discussed this obviously as a group of CMOs, that the engagement or the leadership of the clinicians in those specialties is vital in order to drive the success of these. And we know that some of the areas that are performing the most strongly in these spaces have got very keen kind of clinical leads in those spaces. And that's something we need to develop in maybe some of those areas that aren't quite as strong in the PIFU space. Interestingly, Chair, I'm going to pass on to my colleagues just if there's any questions or anything anybody wants to raise about the specifics of PIFU within any of the trusts. But one of the conversation evolved into us recognising that we've got some services across the group that actually don't perform as strongly, and we recognise that they actually may also be some of our services that are more fragile, and we use the term fragile services quite often, don't we, in these kind of groups and these forums. And we wondered whether moving forward, sorry to be presumptive, Chair, but thought we would guide you from a clinical perspective, that maybe a deep dive or a kind of a review of fragile services and what we mean around that might be a useful thing for board to discuss across the group in the future. So that was where our conversations led us. So lots of joint learning, lots of conversation to be had. Obviously the data is there for people to comment or question on as they wish.
I think that's a great idea, Jules, and obviously David Mowbray shares my thought on that. So I think that would be great to take that forward on fragile services. Questions and or perspectives on the PIFU work. Glenn?
Yeah, thanks, Jules. So in terms of one of my hobby horses on this has often been about whether we are putting patients onto a PIFU pathway when we should be discharging them or could be discharging them from secondary care. So is there any correlation between this and new to follow-up ratio? So have we got any specialties where we've got big follow-up ratios but not much PIFU, i.e. they could be real targets for improvement?
Forgive me, Glenn, it would be disingenuous of me to say I can answer that question right now because I can't. So if any of my colleagues can, please jump in. Otherwise, I will find out for you and feedback.
Could just agree with me. That'd be fine.
Naj, do you have a view on that, or shall we just take it away as an action point?
No, I agree with what Glenn said, and some of the pushback that's coming from some of the specialties is that, well, we've got really good discharge rates, so we have to, I think, when we look at PIFU, we have to do whilst looking at discharge rates in the specialties, so that would be a really good bit of work. And just coming back from George Eliot, yeah, we are. I mean, if you look at the PIFU, we're 3.5 on today's performance on the figures today, whereas the other sort of organisations are much higher. So there is work to be done at George Eliot in particular. And I think the opportunity is there now, certainly with our alignment with SWIFT and, the services starting to work closer for us to look at some of those specialties. But yeah, I think there is more to be gained out of PIFU, working across, say, SWIFT and George Eliot, but across the group. And also, as we start to do the left shift into the communities, we heard earlier on about how some of this long-term condition work is going to be followed up in these neighbourhood care teams, integrated teams, led by primary care. So I think there's more conversation to be had about PIFU out in the community as well.
Okay, let's just pick it up as an action point for the minutes, because I think the fragile services issue is a good one. Tom, did you want to come in before I move over to Francis?
Just to reiterate, we'd equally want further data to answer Glenn's question, but to concur, we do have some areas with some very good discharge rates, which brings their numbers down, and also the use of community pathways, which is another route to reducing those figures back out into the community, away from secondary care.
Okay, thanks, Tom. Francis?
Thanks, everybody. Yeah, the danger of giving people data is that they then want more and ask more questions. But yeah, I think we're in danger, so I'm really pleased with Glenn's comment to solve one problem, but actually that's because we're not doing the right thing. So I think looking at referral rates, looking at with the advent of our community diagnostic centres, how many people then aren't referred because we don't need to have that referral in the first place, and really reducing follow-up. So a broader picture, and the theme that's been throughout the afternoon is, if somebody's doing it somewhere, why can't we have the same level of performance across the group? So really making sure that we are adopting similar policies and procedures, recognising individual clinical practice. But if there's some really good examples, we ought to be able to lift and shift across the group.
Yeah, no, absolutely. Jeremy Shearman makes a great point in the chat box as well. And finally, Stephen, then we'll move on.
Yeah, it's just for this, and it might link to the cancer one as well. I'm really interested in the work that we do with patients and population around this move to these type of models, because I think quite often we present them and then that causes a lot of anxiety, whereas instead what we should be doing is triangulating people's experience or what they would want it to look like if they haven't touched these services, and then that bit of what would make it better. So sometimes when we're in these difficult clinical conversations around moving to these things, having a patient and a population voice in that space is really helpful. Because I think sometimes we get a bit paternalistic about I'm doing the right thing for my patients, where sometimes the patients might actually want something slightly different. So I think we can just think about how we play that in to really push on those.
Yeah, no, point well made. Thank you. Good discussion, team. Thank you very much. We'll move on then, I think, to our foundation group's board calendar of meetings, which is there for reference. You see the next year going off into the distance. Sarah, is there anything you wanted to add on this?
No, thanks, Russell.
Okay, so if you're not happy to approve that calendar of meetings, can you raise a digital hand for me, please? Okay, duly approved. And we've just got some items for information. The first is the Foundation Group Strategy Committee report from the 18th of September, which I'll take as read. Any comments on that, please? So I think we're on to any other business. Any other business from board members? Okay, so I don't think we've had any questions submitted, have we, sir, from members of the public? But as there are members of the public on the line, are there any questions from members of the public? So can you raise a digital hand for me, please? Mike Flaxman.
Good afternoon. An interesting meeting so far. This is sort of 10-year plan related question. We're hearing, I've heard it mentioned several times today about community pathways and the way that can relieve the pressure on our emergency departments, etc. What worries me quite deeply is the state of our community estate to accommodate that, because you can't fit lots of stuff into some of our rubbish community premises because there isn't anywhere to put them. And so I wonder where we're going with the strategy for developing the community estate to accommodate the community pathways that we're talking about. Thank you.
Thanks, Mike. And I think certainly if you take an example like the investment in Ellen Badger, which is now being used by community teams, I think we are making investments. But the principle of what you say, Mike. Adam, your perspective on that?
Yeah, you've beat me to it slightly, Russell. I mean, we have done a fair bit of investment in our community estate. We've done Lillington, we've done Ellen Badger, we've got a number of other areas where we've got good estate. Orchard Centre in Rugby has received some investment. I think in terms of Warwickshire, our worst estate is probably in the north of the county. And we're in a number of shared premises with CWPT, and we've just recently been able to do a deal with them for our worst bit of estate there, which will be a much improved environment for community teams from next financial year. I do agree, though, a lot of those premises are NHS Property Services owned. I think there are some national changes coming with NHS Property Services, which may allow us to have a bit more ownership and flexibility of those premises, which will allow us to invest in them in future. But it is an area we continue to look at. We're looking at our community estate strategy more generally over the coming 6 to 12 months, and we'll update board in due course.
Good to hear it. Thank you, Adam.
Okay. Simon, as a non-exec, did you want to say something?
Yes, I mean, I think there is an opportunity here with the old concept of one public estate and talking to partners about what buildings they may have available. Certainly local authorities, in my experience, will have premises normally in town centres, city centres, which may be useful for public transport purposes, which could be developed. I just throw that in. It's the experience I've had in the past that may be relevant here now too.
Adam, and then we'll move on.
Yes, Simon, that's just reminded me, I should have said, where we've invested in estate, we've generally done that jointly with partners. So if you look at the Lillington estate and the Ellen Badger estate, we've co-located GP facilities, we've received SIL funding from council and so on. I definitely think it's the way forward. We've got some quite well-established local estates forums in Warwickshire, certainly, which are supporting those conversations.
Okay.
Can I just come back again, Russell, on that one?
But buy one, get one free, Mike. Of course you can.
Very briefly, in my own experience, where you relocate GPs into super premises alongside other community services, the cost of the notional rents for the GPs is inevitably more than it was before in their rubbish premises. and the ICB commissioners don't want to pay for it. And hopefully when we become an IHO, we can get control of that and deal with it ourselves.
Fingers crossed, Mike. We look forward to the journey on IHOs, which will hopefully commence next year. Any other questions from members of the public? Okay, team, just one other thing I forgot to mention under any other business, just particularly for Worcestershire staff or Worcester staff colleagues. We do have the Worcester County Council car park available for you to use. It's still being underutilised. And so I would particularly encourage staff who are working on the day shift, because I'm conscious of staff when it's dark, walking over to that car park, to consider using the Worcester County Council car park. We're paying for it, so it seems daft not to use it, because we know the challenges of getting off the site are very real. Ladies and gentlemen, that brings our meeting to a close. We have a confidential board, which I suggest we just jump into at the end of this. Members of the public, thank you for your time today. Leslie, lovely to see you. I hope you found it interesting and look forward to seeing you at either the individual board meetings or the next 4 board meeting. Take care, everyone. Bye-bye.